both from the clinical standpoint and also from the public health point of view, public health nationally and globally. You know, and also from the point of view of recent advances, you know, in management. So it's a very fascinating subject. Today, however, we are only dealing with the clinical aspect, the aspect of diagnosis and treatment. And there's no better person to do justice to this topic than Professor Mokwolu, who is an author. He is one of the authors of the chapter on malaria in the textbook of Pediatrics and Child Health in the tropical region. So it's a privilege to hear straight from the horse's mouth at this meeting. Malaria, of course, is a very important subject for pediatricians in private practice who find ourselves, you know, as often as primary care physicians having to treat these children firsthand. Sometimes some of us even treat adults with malaria. So, you know, it's a topic that we must be at the cutting edge all the time. And perhaps I can even venture to suggest that this meeting, this malaria meeting, should happen at least every year, because there's so much happening with malaria. Things are going very fast. Things are changing very rapidly. So I welcome everyone again. I am also very privileged to welcome Professor Mokwolu to this meeting. Please, let's relax and have a very, very interesting time, which I'm sure Dr. Mokwolu is going to give us. Thank you very much. Over to you, Dr. Elichu.
Thank you very much, sir. So, Dr. Dushate, you have the floor.
Thank you, sir, my big boss, so on many fronts. Thank you for the privilege and honor to be able to do this. Well, I've known Benga for many years. He's an Ibadan Medical School graduate, and he's demonstrated leadership quality over the years. To put in perspective, Benga became the subgroup leader of my clinical group, and we didn't have cause to overthrow him or deport him or to demote him. So he led us successfully for the 3 years of clinical school. And after school, he still contributes meaningfully as part of the leaders of our group post graduation up till now. And Benga developed his flair for pediatrics over the years, and his passion initially was neonatology. But as a child of destiny, he was given an opportunity to veer to malaria. And as God will have it, he had all it takes to embrace the challenge. And he has distinguished himself over the years in the field of malaria and is a leading light globally. So I'm not surprised that he was in the US, he has crossed over to UK, and then I'm sure he's on his way back home to his loving wife. And some might not know this, we've come a long way. I won't tell you more about the long way, but trust me, I know Benga like I know myself. And I expect that he will do justice to the topic, and I'm sure we'll have a robust discussion today. So Benga, go for it. Thank you.
Thank you very much, everyone. And I'm highly privileged to be in our midst today. As I said earlier on, I mean, my great teachers, my very senior mentors, colleagues alike are on this forum, and I think it's a very great privilege to be here. I'm told that it is a very time-conscious activity, so I will also not want to waste any much time. Today, we are looking at updates on the diagnosis and treatment of malaria for pediatricians in private practice. And I see pediatricians, and I've also seen a few others in different categories also on this in this meeting. So it's a privilege to be here. So let's roll, as they will say, and have about some 40 minutes of interaction. So I just finished my courses, but I think it is important to underscore that the pediatric private practice is unique from the point of client expectations. human resource deployment, and the competitive environment. If you are not going to be there, you will need to look for somebody that looks like you. That is what makes the practice particularly unique. When you want to engage, you're almost thinking of the skill set that you offer. And those are the kind of things that we put on table. So it requires the fine balance of expert service, affordability, and the characteristic empathy of pediatricians to their special clients. Well, talking about malaria, as you know, Nigeria accounts for 27% of the global malaria cases and 31% of the global malaria deaths. If you bring it down to Nigeria, we have about 68 million clinical cases annually and about 198 malaria-related deaths annually. And if anything, if we are to go by data from the Malaria Indicator Survey, about 45.5% of patients visit the public health sector, and another 54% of patients visit the private sector. I know that private sector, when it comes to health service, is very heterogeneous, but within that, you have the formal private health sector, and then we have the informal private health sector. So what I'm getting at is that we as pediatricians in private sector, we see quite a reasonable part of this clientele that we're talking about. So malaria will constitute about 1/3 of hospital admissions and 2/3 of outpatient visits. Very quickly, without going into too much elaboration, malaria for the purposes of treatment or management is classified into uncomplicated malaria and severe malaria. I'd like to underscore this classification because it is one of the first things that helps us to get it right. Once we're able to get it right, particularly the pressure in the private sector, whereby we have parents to worry about, this classification becomes one of the most important things, because once you get it right, then your next course of action is generally determined. So uncomplicated malaria is symptomatic infection with malaria parasitemia without evidence of vital organ dysfunction. Okay, and basic symptoms will remain things like fever as the main manifestation, either present by history or during the period of evaluation, chills, rigor, depending on the age of the patient, whether they can complain about chills, but rigor that can be visible, and then other complaints also reflected by the age of the patient, headaches and other body pain, feeling unwell, nausea, joint weakness. And then for the signs, it may be that all that we will be able to elicit will be fever, but sometimes we might see hepatosplenomegaly, and then we could see halo. But important within the signs is, where possible, the exclusion of other immediate causes of fever that we can identify or elicit. When it comes to severe malaria by definition is acute falciparum malaria with vital organ dysfunction. And patients with falciparum asexual parasitemia and presence of one or more of the following. So if you want to make the definition simple, you just say acute falciparum malaria with vital organ dysfunction. But let me say that for our purpose, both Plasmodium vivax and Plasmodium nosai are two other species that can cause severe malaria. I'm taking liberty of the fact that Plasmodium nosai is reported largely in the forested region of Southeast Asia, and it is more like a zoonotic infection because the macaque monkey is responsible for its transmission. I'm also taking liberty of the fact that Plasmodium vivax, though you have 1 or 2 reports of it in our environment by PCR, is largely not prevalent here at all because of the transmission requirement for those of us who are non-white skinned people. Okay, so that is why for this purpose, I can take falciparum malaria as the default malaria responsible for severe malaria. But in any case, at all times, falciparum malaria is still the one, Plasmodium falciparum is still the one most frequently responsible for malaria and responsible for the severe malaria significantly and responsible for the most fatal outcomes. So severe malaria will therefore, if you want to be very specific on the classification or definition, we will now say it is P. falciparum asexual parasitemia in the presence of any of the following listed laboratory features. And what are those features? Impaired consciousness. I might not be able to explain all the description, but impaired consciousness as indicated there. Prostration, that is generalized weakness, so that the patient is unable to sit, stand, or walk without assistance. Multiple convulsions, by definition, more than 2 episodes within 24 hours. And then these other parameters like acidosis, hypoglycemia, and severe malaria anemia. This is quite often very common. If anything, the most common complication that we are worried about. So this is hemoglobin concentration less than 5 grams per DL in children less than 15, and in children less than 12 years, and less than 7 grams per DL in older children and adults. Okay, then renal impairment. And jaundice, I must underscore that jaundice is not an isolated criterion, but if there is other abnormalities, particularly a parasite count greater than 100,000 parasites per microliter, then that jaundice in this context becomes significant. So ordinarily, it is not an isolated parameter just by itself. Then pulmonary edema, significant bleeding, the patient being in a state of shock, and hyperparasitemia, which in an area like ours where malaria is endemic, is defined as a parasite count greater than 250,000 parasites per microliter of blood. And in areas that is low transmission, that will be 100,000 parasites per microliter of blood. That's hyperparasitemia. So even if the person is asymptomatic but has hyperparasitemia, that is severe malaria, from the fact that by the time more than 10% of the red blood cells are parasitized, whenever those parasitized red cells, whenever they are still going to hemolyze, and some of them will also still be broken down, even for those that are not parasitized. So by the time you think about all of that destruction of red cells taking place, is ultimately going to tip the patient into one other complication or the other. That's why we treat hyperparasitemia, even if it's asymptomatic, as severe malaria. The question that arises, of course, and I'm grateful, this is already over about 100 participants on this webinar. So the question arises, does a pediatrician need a guideline to manage malaria effectively? After all, we have our skills, we can make the diagnosis accurately and all that. Well, I believe that our attendance here suggests to me that you have answered that question personally. I think that there is a place for us to understand the guidelines, and we'll look at why do we need to understand these guidelines and what did they say. So this is the latest edition of the National Guidelines for Diagnosis and Treatment of Malaria in Nigeria. We also have the WHO. What the WHO has done now is that instead of producing versions of the guideline annually, or periodically, WHO no longer does that. We just have something called the WHO Magic App. where guidelines are updated continuously. So it's a living document. So whenever you get into that document, it warehouses all recommendations about malaria management from prevention to treatment. And any recommendation that you are reading there, you are going to find out that it is dated. So if there is a statement, you might find out that it's a 1999 statement. So it will do well to check whether there is a more recent statement in that particular regard. So they will always state the date of the last entry into that document. So it's a living and continuous document. But this is the 2020 version of the national guidelines, which is well aligned. Why is this guideline important? It is for standardizing diagnosis and treatment practices following the best available evidence. It helps us to harmonize malaria management within the country, and it incorporates new data and new tools to address changes in the disease burden or in the demographics. And it is well aligned with the WHO treatment guidelines, but reflecting the unique characteristics of the country. So what are the important statements of the guideline? We just go through them. So each time you see what looks like this target sign, then I'm trying to quote verbatim the statement from the guideline. So with respect to diagnosis of malaria, the verbatim statement is that all suspected malaria cases should have a prompt parasitological confirmatory test using either microscopy or malaria rapid diagnostic test. Let me draw attention that we haven't said prompt laboratory tests. It is a prompt parasitological confirmatory test. This is to allow us to use the RDT. It doesn't have to be lab-based. It can be on somebody's consulting table, or depending on how we have organized the workflow. Okay, but a parasitological confirmatory test is mandatory before we treat. Why is that so? Let's look at our country. As I said, okay, this might be updated. About 68 million cases of malaria occur in the country every year. But when you look at our anti-malaria consumption, it is almost 2 to 3 times this volume. The one that is through the official channel is about 2 this volume. When we add the entire private sector, it is almost 3 times this volume. And so what does that suggest? Is because we are doing inadequate testing, and there is a lot of over-treatment that is going on. And with a lot of this treatment, we sometimes delay in recognizing the true cause of fever, okay? And something that may be more potentially harmful. So testing for malaria therefore helps us to identify true malaria cases. It makes what we are doing efficient, and it leads to rational use of medicines. So, I mean, I won't insult our intelligence. This is just a brief overview that somebody has fever. We want to think of infections, then we can dilate that bacteria, fungal, viral, all of that, parasitic. Then we want to think of reactions like drug reactions. We want to think of certain tissue disorders, connective tissue disorders, then malignancies. We want to now think of some environmental factors, particularly like in the newborn where I am. I just find babies. We reported something that we call evening fever syndrome in our babies. You know, the environment is very hot. The wall holds on to heat. In the evening, they release the heat. And then you are doing ward round and just found out that babies are warm in the evening, and there is a tendency to be pushed into starting antibiotics. So what we also normally do is that once we see that if the baby is not otherwise symptomatic, we keep the baby exposed, we take auxiliary temperature and take the rectal temperature or any core temperature. If the gradient of the temperature is from within to outside, that is, the internal temperature is higher than that of the skin, normally we know that core temperature should be higher, but if when we do that, we still find the core temperature higher than the skin, then we know that the baby is cooking from inside. So we are worried about sepsis. But if we find a reversal of that gradient, that the skin temperature is higher than the core temperature, which is not what we expect, then we know that the baby is being warmed from outside due to environmental factors. So we expose the baby. Within about 2 to 3 hours, we'll have seen the temperature go down, and we don't have to use antibiotics necessarily. It appears we have exceeded the limit of this Zoom meeting. There are a number of people still wanting to join. So that.
Sorry, we can go. We're actually going to post that you can join the Zoom platform, YouTube version of this platform. We'll announce that. Sir.
All right. Okay. Thank you. So diagnosis of malaria. So as we continue, we just want to emphasize that malaria cannot be diagnosed based on clinical assessment alone. Diagnosis requires this parasitological confirmation, and a comprehensive clinical history should be obtained. Signs and symptoms are non-specific, and clinical examination should be thoroughly done. And when it comes to reporting the testing, these are the approved methods of reporting. If it is an RDT, it should be reported as positive, negative. If it is microscopy, it should be reported as malaria parasite seen. And where possible, they should tell us the species that they have seen. Okay? So malaria parasite seen or not seen. But once you say malaria parasite seen, you can endeavor to tell us what you have seen. This will reduce arbitrariness. If it is a more sophisticated environment, they can even go ahead to tell us the parasite density. That may not be feasible in a routine care, but some of our clinics at the private level, they get quite sophisticated, and at times you can call for this, especially if you are beginning to think of severe malaria. Okay, but the whole plus sign is currently recommended to be discarded because it is of very minimal value. It just shows the temperament of the person behind the microscope. When they are happy, they give pluses. When they are not too happy, they say something like scanty. Okay, now, still driving home the point of why the testing is necessary. I'm presenting a personal data here where we were recruiting people suspected to have severe malaria. So these are situations where the person meets severe malaria defining criteria. And after we have screened them, when we now tested them for somebody whose primary characteristic is severe malaria defining. I hope you get what we are saying now. Only 48.2% of them were positive. So you can now imagine that if you are talking about just fever coming from the community, so we do quite a lot of overdiagnosis of malaria, okay? So when we tested people with a starting criteria of severe malaria defining, only less than 50% were positive. So let's just say, for the sake of argument, about half went on to be confirmed as malaria, and only those ones were then subsequently treated. So I just wanted to show the first part of this particular flow chart, just to emphasize that malaria needs a confirmatory test. That's just the point I'm still emphasizing. Then when we have tried to look at variabilities across the country through the therapeutic efficacy studies, we see that Northwest is still returning the highest test positivity rate, Northeast, 59, almost 60%, then North Central, 48.3%, South-South, 46%, Southeast, 36%, and then Southwest, 25.2% of those who have fever who tested positive. I have not yet included this year's data, but I can tell you that when we add this year's data, these various averages are also going to come down, okay? This is a data being collated since 2018. So you can imagine that as the malaria reduces, the averages reduces. I made these averages across the years just to see how consistently each of the zones are behaving. But in terms of our test positivity rate in 2020, the average from our study was 60.1%. And then in 2021, it came down to 42.5. Currently, as it is going on now in the country as we speak, it is currently averaging 25.7%. So when we say test positivity rate, it's the number of people with fever who are symptomatic that you have tested and for malaria and who proved to be positive. So you can see that the proportion is reducing. So the basis for carrying out an empiric treatment is getting even more and more reduced, because now, if initially you could even say it was acceptable, the more you reduce the proportion of malaria contributing to the fevers, the more you need to test so that we can begin to treat other causes of fever that are not malaria. And this particular further illustrates it, that if you were to start treatment in an empiric manner, what is it that will happen? You have some population of patients and you decide to treat empirically. For those that we have given those treatments to, 60% of them are going to be false positive, and then another 40% of them will be true positive. So you can see the amount of wastage that has happened here. And if we now go on to test those ones, we'll be able to sort out those who are true negative. So, and then those are now true, I mean, maybe even with our test, there might be a little false positive. But this whole quantity will have been true negative that will have been detected if we tested and will not have used our drugs for them, and will give them the benefit of considering other diseases. So this model just further illustrates the value of parasite-based diagnosis. So what are the options we have? We have RDT, we have microscopy. RDT is not a screening test. RDT is a diagnostic test. Okay, it may have its limitation, but it is a diagnostic test. You don't approach RDT as if we are going to confirm with microscopy. It is a diagnostic test that works on its own mechanism. Microscopy works on its own mechanism. Even when we say microscopy is gold standard, that is true. It is based on the overall characteristics of microscopy, okay? So RDT is fast, it is easy, it is reliable, and as we said, it should not be regarded as a screening test. Microscopy, on the other hand, allows for direct visualization. We can do thick blood film and thin blood film, okay, for microscopy. And it helps us. This is an example of thick blood film. And so thick blood film helps in parasite identification and parasite density. And then the thin blood film helps in speciation as well as parasite density. We don't have too much time, so that's why I'm not stopping to explain. But one key thing about microscopy is that there are issues that we must pay attention to. Number one being the skill of the microscopist, the quality of the film, the quality of the microscope, and the quality of reagents. Any of these things can affect our microscopy result. And particularly for us in private practice, I want to strongly suggest that please organize that your microscopist undergoes the requisite training. Coming out of any certification of laboratory technology course is not sufficient to make somebody proficient in malaria microscopy, okay? So these are the issues, so these are the needs. The microscopists need training, they need to be validated, the microscope needs proper maintenance, the slides needs to be done very well, and then we need to have our standard operating procedure, capacity for reading the slides appropriately, and all that. So this is just quality assurance around microscopy. So when we say microscopy, we actually are referring to quality microscopy as carried out by an expert. So we talk of expert microscopy. This is just a paper to now show what happened. You see that in this particular paper, when they were not doing parasite-based diagnosis, everything just kept on and remained on a straight line, as if there was no effect at all of intervention. But as soon as they started parasite-based diagnosis, the case incidence went down. And let me say to us that the more we imbibe parasite-based diagnosis, the more we are likely to get to a point where we can suffer some significant challenges. Let me not call it embarrassment, because if without this diagnosis, you treat 7 out of 10 fever cases for malaria, you might find out that when you start testing, it may not be more than 3 out of 10. And there's a tendency to disregard things like the RDT and say they are not working. I can assure you that they are working perfectly. It is just that we are facing the reality. So what is the key message here? That parasitological testing, sorry, let me leave this thing. Yeah, parasitological testing to confirm malaria is mandatory. It is the correct practice and it is cost efficient. So that's number one update on the treatment guideline. Okay, the next thing is treatment of uncomplicated malaria. The artemisinin-based combination therapies are the recommended treatment for uncomplicated Plasmodium falciparum malaria. So what are the ones that are available in the country? We have artemether lumefantrine, artesunate amodiaquine, dihydroartemisinin piperacin, and artesunate pyronaridine. Okay. All these 4 are currently approved for use in the country. For purposes of standardization, the number 1 of them is artemether lumefantrine. They are all co-equivalent. They are non-inferior to one another, but we deploy artemether lumefantrine preferentially, but then any one of them can be used. That's the truth of the matter. So those are the recommended ACTs for treatment of uncomplicated malaria. As much as possible, there is no place for monotherapy in the treatment of malaria. All of them are given for 3 full days, except for artemether lumefantrine that is given twice a day. The rest of them are single daily dose administration. Again, to assure us, I need to inform that the National Malaria Elimination Program, with support from the Global Fund and the President's Malaria Initiative of USAID, have continued to track the sensitivity of currently recommended anti-malaria medicines to ensure the best evidence in the country. And this is evidence of the regularly conducted therapeutic efficacy studies showing geographical spread and, the inclusion of different states. And you can see the numbers that are being recruited into the study, and we go on to a molecular level of analysis just to reassure us that we are tracking. And you can see 2023, I said it's ongoing. So you can relax and trust the recommendations for now. This is just showing you a summary of what happened in 2018 and 2020. It was planned for 2019, but it was 2018 and 2020. So you can see here, when it was done in Kano, the 28 adequate clinical and parasitological clearance cure rate, was 100% for artesunate amodiaquine and artemether lumefantrine 97.9%. We have a 95% benchmark. In Enugu then, artemether lumefantrine 98.9, dihydroartemisinin piperacin was 100%. In Plateau at that time, artesunate amodiaquine was 97.8, and then artemether lumefantrine was 97.8 also. So we see this data We have a similar data for 2020. 2020, we have data also for 2021, and we are currently on 2023. Okay, so this is evidence-based. In less than 2 days after the commencement of treatment, all of them achieved more than 90% parasite clearance. And by the second day, they were getting the additional levels such that by the time they finish, we are still recording good parasite clearance for all the drugs. So again, this is a map showing the parasite clearance. This is artesunate amodiaquine, artemether lumefantrine, and dihydroartemisinin piperaquine. You can see all of them. We initiate treatment, look at the response in 1 day, the response in 48 hours. Okay, the response in 48 hours. By the 3rd day, there's parasite clearance, and it stays that way. From 14 days, we might begin to see some parasites showing up again. These are usually where we want to differentiate between recrudescence and reinfection. And when we do the PCR correction, that is why we are able to say that we still have over 97% cure rate for all the ACTs that we are currently deploying. So ACTs are working. Your biggest problem is making sure that the diagnosis is malaria. I have engaged with several people on this contentious issue, and thankfully, I'm yet to be proven wrong. Then, again, look at this particular interesting picture that just when we treat with the ACTs, look at what happens to the hemoglobin concentration. There was no hematinics, there was nothing, but in response to treatment, we can see the hemoglobin concentration also improving. So there might be some scattered reports that the ACTs, they lead to hemolysis or something of that nature, but this is the data. There might be an initial gentle decrease, but you could see that ultimately they recovered and they did well. Okay, so this is the full TAS result that is showing this level of sensitivity. And then we went around and did molecular markers for resistance, and we did not find evidence of resistance so far in the country. So we are tracking, we are conscious of the fact that there is partial resistance reported, but currently, I hope I'm able to show us that the current guidance that the country is still giving is based on evidence within the country. Okay. I will not have the time to go through this, but there are dosage regimens by which we can use. Okay. So there are a few specific things to consider. If the patient has a temperature greater than 38.5 degrees Celsius, you may want to give paracetamol, okay, along the treatment. If the patient is vomiting, then we can give paracetamol and then administer the dose. We watch that patient. If the patient vomits shortly after that, we can repeat the dose, okay? Before considering having to use a parenteral treatment. And I'm going to talk very shortly about the popular parenteral treatment that is called EMAL, that a lot of people believe very strongly in. And if there are seizures, of course, it has to be aborted in the standard way. Certain other gray zones in children who are less than 6 months, particularly neonatal age group, we still use the same dose of ACT as any child who is up to 5 kg. It's just that we might use a dispersible and use such type of pediatric formulation. Now, very, very specifically for pregnant women in the first trimester of pregnancy, this is a 2023 update. First trimester of pregnancy, confirmed malaria it is treated with artemether-lumefantrine. That is the current WHO recommendation. Quinine plus clindamycin, as previously recommended, has been shown to be associated with poor pregnancy outputs. Where we don't have artemether-lumefantrine, and it is because maybe by country policy or something it is not available, then other ACTs can be used, but not artesunate pyronidine, because there is no data on it at all. So no recommendation can be made yet. In this particular case, artemether-lumefantrine is recommended as against even all other ACTs. So it is not just any ACT. All right, the evidence available primarily supports artemether-lumefantrine. For the other ACTs, the evidence is not yet sufficient, even though there are no alarms, okay? So that is why the recommendation is very specific for artemether-lumefantrine in the first trimester of pregnancy. In the second trimester of pregnancy, any ACT can be used. So what are the key messages about treatment? ACTs are the recommended treatment for uncomplicated malaria. They retain over 95% of efficacy in Nigeria from routine TES surveillance. The current issues around artemisinin partial resistance calls for alert, but not yet reported in Nigeria. And they currently continues to track anti-malaria sensitivity, and we always provide updates through the NMAP. The third guideline statement I would like to present to us is about severe malaria, which is a medical emergency. After rapid clinical assessment and confirmation of diagnosis where possible, commence immediate treatment with parenteral medication. And intravenous artesunate is the first treatment of choice for severe malaria, for severe falciparum malaria. Again, here, I want to emphasize that the artesunate is no longer artesunate or artemether or quinine or artemether. No. The drug treatment, specific anti-malaria treatment, that is not putting aside all other considerations. The specific anti-malaria treatment is artesunate injection. So please kindly bear this in mind. That's the recommendation. So the management approach is simple: rapid history to document the situation of the patient, conduct our physical examination to identify probable cause of what we are dealing with and assess all systems, confirm parasitological diagnosis. There might be other investigations that are necessary, many of which are available through point-of-care devices that we can rapidly assess so that we have a quick overall picture. The following are evidence around this recommendation. When quinine and artesunate was considered together in what we call the SEQUAMAT trial, there was a 34.7% relative mortality reduction by artesunate compared to quinine. When these two drugs were compared in an endemic country and in children in the AQUAMAT trial, there was a relative 22.5% mortality reduction in artesunate over quinine. And when artemether and artesunate were even considered, there was a 46% relative mortality reduction. And so artemether is not even here at all. Artemether is a first generation artemisinin compound. It is no longer mentioned anywhere in WHO documentation. It is popularly sold around as EMAL, and so many people use EMAL. Can I please beg of us that whatever stock of EMAL we have can be so discarded today, okay? It is like bringing in an expired product, a product that is no longer recommended for use at all. So we as specialists, pediatricians, we should not be found anywhere near EMAL, okay? This is evidence between artesunate and quinine, and we can see how the survival curve shows artesunate performing much, much better than quinine, both in Asia and then in children in Africa where malaria is even endemic. Okay, and so this is what informed the recommendation of WHO and said that intravenous artesunate should be used in preference to quinine for the treatment of severe falciparum malaria in children. It is a strong recommendation, high quality evidence. In coming to this recommendation, 4 trials were reviewed, over 5,000 participants were enrolled. So I want us to see the strength of this evidence. It is only when artesunate is not available and not by preferentially stocking it that we use either artemether or quinine. And the dosage is for children less than 20 kg, not age less than 5. It is a weight-dependent issue. For children less than 20 kg, artesunate 3 mg per kg is administered, and then for adults or children greater than 20 kg or adults, artesunate 2.4 mg per kg is given in these specified times of 0, 12, and 24 hours in the first 24 hours, and thereafter once daily until the patient can take orally. Okay, there is no upper limit to the dose of artesunate. Whatever we calculate in milligram per kg, that is what we administer to the patient. If it is not available, that is when we can then go ahead to use artemether or quinine. But as I said, please do not use artemether. And once you have initiated parenteral treatment, it must be given for a minimum of 24 hours. But once the patient takes orally, once the patient can take orally and we switch to oral, then we give follow-on treatment with oral ACT, and it must still be for 3 days without subtracting the duration for which we gave parenteral injection. Okay. Sometimes before people come to us at the community level, at times they might come just for us to be aware. We recommend that for pre-referral, they can, in children this time around less than 5 years or 6 years, they can use rectal artesunate or artesunate IM or artemether IM or quinine IM in that order of preference, But where it is an older person, 6 years and above, due to certain evidence in some of the studies conducted, rectal artesunate is not recommended. So for pre-referral, they either use IM artesunate or artemether or quinine. Number 4 recommendation has to do with chemo prevention. So chemo prevention is the umbrella for all the drug-based preventive strategies for malaria, and there are different types. Okay, so we have so it includes chemo prevention as well as chemo prophylaxis. So, but when we say chemo prevention specifically, a typical one that comes to us is intermittent preventive treatment of pregnant women by giving them SP. Okay, I'll talk about that in another slide. Intermittent preventive treatment of infants. It has now been changed to perennial malaria chemo prevention and no longer limited to infants. It's been extended into the 2nd year of life. It is currently as a implementation research level in the country. Then there is a seasonal malaria chemo prevention, which involves the administration of SP and amodiaquine. This is deployed at a national level. It's not for private consultation, and it is for areas where there is seasonal malaria transmission. So if you divide Nigeria into 2, anywhere from Middle Kwara along the north-central axis upwards, they represent about 21 states that are practicing SMC, and it is coordinated by the National Malaria Program. And then we have the malaria vaccine, okay? So the one thing about IPTP is that now it is recommended to start from 13 weeks of gestation, not from quickening. And it can be administered monthly, not just 2 doses, monthly until the last month. So those are some slightly different issues. For sickle cell disease, for those who are already on proguanil, don't stop your proguanil. We are still looking for better strategy for chemoprevention or chemoprophylaxis in sickle cell patients, but encourage them to use complementary items like the nets, and then to treat malaria cases when it does occur. I'm sorry that my background has become slightly noisy, but I hope you can still hear me well. Then for non-immune visitors to Nigeria, which I guess many of us here may be encountering as specialist pediatricians, chemoprophylaxis needs to have been commenced from their home country before coming into Nigeria. But when they come to Nigeria, they continue. The options are limited. It's usually either Malorone, Atovacone plus proguanil. It's either that Malorone that is given, or they also can take weekly mefloquine. That is usually the options that are available. And then when they are in the country, we give them information about early recognition of malaria, if possible to have an RDT kit, and then, but more importantly, to have what we call a standby treatment, a dose of the ACT with them, and we encourage them to also use the nets. All right. So this is what I have said about prevention in pregnancy. From week 13 of pregnancy, avoid high-dose folic acid for 7 days after, when using SP, or we can give low-dose folic acid, which is 0.4 milligrams. So we discovered that if we do these things, we will contribute into a reduction in the malaria burden. I just wanted us to see this chart. We have advanced beyond this chart now, but over time, the malaria deaths and the malaria cases have been coming down, showing that if we continue to do the right things, we will have a sustained effect. For those who are practicing in Lagos State, they will know that as you test and you truly test, the proportion positive are really becoming quite scanty. And so this is the progress that is being made. And I want to charge us to stay along this line. I want to thank you for your attention and to show you here that what we have projected is that if we continue to do everything and we are able to deploy 80% of all our interventions, we will have reached a remarkable mark in terms of reduction in malaria burden by 2025. I thank you very much for your attention. Sorry, I had to make it very brief because I also know that we are very busy people and we have limited time. Thank you very much. I'll stop here and take some questions.
Thank you, Gbenga, for your lucid, robust presentation. And I'm sure we are limited with time. So if you have questions, can you please put on chat box so I can take more questions, because we have different time to roll. Secondly, if you must ask, please kindly put up your hand and I will recognize you, and then you can now ask your question. So if you must ask, you need to put up your hand digitally so I can recognize you. But preferably, we would like to put on the chat box because we have limited time to wrap this up. Gbenga has another pressing meeting he needs to attend to in about 10, 15 minutes time. So any question that's burning issues, you can put on chat box or you can put your hand up digitally. I think for me, there are many takeaways about the need to test, the evidence that's robust for the choice of drugs to use now, and the new guidelines for pregnant women. So any question, no, I remember in those days in medical school, aka the malaria man himself, he said either he has wasted his time by talking to him if you have no question, or he has done a good job. I'm sure Benga remembers the malaria man himself.
Yeah.
There are a few questions in the chat box.
Okay, I'm trying to look through. Okay, there's one by Professor Ogun. False negative microscopy because of cytoadherence or prioritized RBC, development of knobs like predictions. So I think you can read that. That's basically what it's saying. It says, please explain and advise treatment steps. I think you have talked about pregnancy thing. Yeah. I think I've answered that question, sir. Yeah. I don't think there's anything.
And so actually, with expert microscopy, the issue of false negative for microscopy doesn't really arise so much. By the time somebody is symptomatic, there is a certain level of parasitemia that makes it patent parasitemia. And so such things are really, really reduced to the barest minimum occurring. But the point that has been made about sequestration of the erythrocyte is noted. That is why we are advised that for malaria parasitemia, please use capillary blood. That is, take it from a prick, not from a vein, if possible. The one that you want to use for malaria parasite, please take it from a prick. That means you are entering the capillary bed at that point in time. Thank you.
Sorry, there's a question about temporary for sickle cell malaria. So a few patients have reported reaction to proguanil. What are the options available?
Yeah, so for now, there is still a search in order to change the approach to sickle cell disease. But if somebody is reacting to proguanil, then you use preventive strategies like LLIN, encourage the person to sleep under the net and how to present in case they become symptomatic. But we are currently working on a different approach that will look like the combination that we are using for SMC. But the evidence has not reached a level to change recommendations so far. There is actually a publication in that regard, but we have not reached a critical point of the evidence.
So, sorry, this is also about sickle cell patients. That if you have used ACT to treat them, do you continue with the proguanil after treating with ACT? Immediately after treating with anti-ACT? What's your recommendation, sir? So you have a patient that was treated with ACT, and then they continue their...
You know, for them, they are on chemoprophylaxis. I hope you get me. So, and if you look at a typical treatment, the duration of your drug is about 28 days. Some drugs will last longer. And once the therapeutic value of that drug has waned away, then the person can be susceptible to another infection. All right. So if you now have a situation where because of the person's condition is more susceptible, or you don't want it to occur so that it doesn't precipitate crisis, yeah, you can continue your prophylaxis. That is not a big issue.
Sorry, this is from Maria Mukhtar.
Yeah.
What's the truth saying? How is the truth saying that you must give vitamin C with your ACT?
Oh, no, nobody has said that. Nobody has said that. You can delete that information.
So secondly, what's your current recommendation for neonatal malaria? Current recommendation for neonatal malaria?
So the number one is we have to prove it. We really have to prove neonatal malaria. So, and it falls into two categories. If it occurs in the first week of life, that's congenital malaria. If that person is not symptomatic, because in most cases, congenital malaria is not symptomatic, I will counsel that you observe that person closely and maybe repeat that test again. But malaria occurring after the first week of life is neonatal malaria, and you treat with ACT at the same dose as you will have given for a child less than 5 years. 5 kilograms at the same dose that you will have used. So ACT, we are using artemether lumefantrine, give artemether lumefantrine to a newborn.
Well, this is a question from one of our senior colleagues based in UK. He says, is RTD kit easily available? And what's the cost effectiveness of in private practice? Without a cost?
It is quite available. It can be easily accessed. All we need is to increase demand for it. Some pharmacy stores, they sell RDT. One of our colleagues, well, not a medical doctor, but one of our colleagues, Professor Wellington Oyibo, is actually responsible for conducting quality assurance tests on the RDT that are imported into the country. Okay, and for a private practice, it is actually very cost effective because one, it improves your confidence of treatment, it helps your reputation in treatment, and you are able to factor that cost by the time you explain to the person the basis of what you are doing. And it helps you because you can reach a decision very quickly in the course of your management of that person. So when we've done cost analysis, it's quite cost efficient, even in a private setting. That is the desirable pathway to go for your reputation, for the sake of the patient, for making sure that the right treatments are provided. And even from the cost analysis, it shows that it is the better approach to do.
So this one is coming again for pregnant women. Why can't we use high dose of folic acid in IPT in pregnant women? So say, why can't we use high dose?
Yeah, it is the interference with the sulfonamide component, the sulfonamide component of the SP. So you don't want to, you are giving the drug for something else and then another product is there to counteract the effect. And that's why you give just a low dose folic acid, which is otherwise sufficient for the purpose for which you are giving folic acid in pregnancy. The 5 milligrams that we are giving regularly is like a working dose, actually.
So, but last but not the least, Ali, because this is my friend now. Chief Unai, can you unmute and ask a question? He's my friend. I invited him, so I will yield.
Okay.
So, Chief Unai, unmute and ask a question briefly before we close.
All right, Prof. Thank you very much for this talk. It's quite enlightening. I want to ask, in the event that we don't have the RDT and we can't do a microscopy for malaria, can we use the periodicity of the fever to determine if it's malaria or maybe an infective process, whether viremia or bacteremia? Is there room for periodicity?
No, it is not pathognomonic. It is not pathognomonic. And honestly, you know, the way I would like to answer this type of question is to say that, is there a conservative management for acute appendicitis? So we need to get it to that level to begin to appreciate the mandatory nature of diagnosis. And you will, if you don't have your RDT and you don't have a capacity for diagnosis, let it be as if you don't have.
No, go ahead. It's an interference, sir. Don't worry, just go ahead.
Let it be like you don't have an ambu bag or you don't have petrol in your car. That's the way we should begin to look at it, so that we do everything to actually make it available. This is private practice.
Okay, so this one I cannot go in from. It is for my teacher, our mother in pediatrics, Professor Grange. What's the experience with vaccine in children? This we have to ask. What's the experience with malaria vaccine in children?
Well, We have not deployed it yet in Nigeria, but I'm familiar with the literature position. So the evidence today supports some form of 30% reduction in severity of malaria. It requires 4 doses to be administered in order for us to have the protection that is necessary. But how long that protection lasts and such other considerations are further issues that are being looked into. There is one licensed vaccine, and there is a second one that is coming up very fast, for which NAFDAC in Nigeria gave an emergency authorization so that it can support research in that particular, on that particular vaccine. So vaccine will add, but so far there is nothing to suggest that vaccine will displace all other preventive strategies, but it will be a complementary tool for now. And then once we have started with one vaccine, the knowledge around vaccine will escalate very rapidly. And I don't know tomorrow about vaccines, but it's a very important addition to the fight against malaria, and we should support efforts by Nigeria to lay hold of the malaria vaccine as well. Thank you, ma'am.
Thank you very much, Benga. This is the very last one. No, good press asked the last question many times. So somebody said that, well, RDT is good, but if you have evidence of sepsis and RDT is positive, do you still go ahead and treat for malaria and then still look for sepsis?
Well, yeah, malaria can coexist with a bacterial infection. So if you have evidence of sepsis, that evidence should be incontrovertible. And if RDT is positive, that is also another incontrovertible evidence of malaria. Actually, in severe malaria, there is close to 30% occurrence of concomitant sepsis. And so we strongly recommend being very deliberate in actually searching for bacterial infection, even when there is an established diagnosis of severe malaria due to that association. But we are pediatricians, we will not recommend a blanket administration of concomitant antibiotics yet. Those considerations are being discussed, but we have the capacity to discriminate and to be able to check and confirm sepsis, and then we give our cephalosporin to treat it when it does occur. If somebody has uncomplicated malaria, otitis media, pharyngitis, all of that, but also happens to test positive for malaria, that is an evidence before you, because provided we are certain that this is not a false positive type of test, in other words, we trust the skill of the person, or it is positive by RDT, then we should treat the person also for malaria. But please, let's not treat anticipatorily. Let us treat on the basis of evidence.
So thank you, Benga, for this. But very, very last one. So this
that is Dayo, that has.
No. This one I have to say, because when I was LOC chairman for some association, he bailed me out. The senior colleagues, he said UTI, United Diagnostic Kits for malaria, is on television. What's your take on that, sir? And I think it's very germane to ask that.
Which one is that? UT?
No, the kits that uses urine to diagnose malaria.
Urine malaria test, UMT.
Yes.
Yeah, so urine malaria test is a fairly recent innovation, and we welcome that innovation. The body of knowledge and science around it is not yet at such a level to give us all ramification of information that we need to be able to speak to every situation and circumstance. However, if you have somebody who can void urine and you have the test kit, it is equally good. it doesn't have the same level of accuracy as RDT, okay? And we are still trying to understudy what happens, for instance, if the urine is contaminated with blood or any other thing. But it is an added facilitation of diagnosis, but we have not been able to bring it to a level of saying it replaces RDT, but definitely it advances the frontier of diagnosis, particularly in more peripheral areas where there might be no capacity to collect blood or things of that nature. So it is an added thing, but your blood RDT, for now, we can answer all the questions around it. For urine malaria tests, we cannot yet answer every single question around it.
So Dayo, just go for it quickly before we go, so that we won't be.
Good afternoon, excellent talk.
Thank you.
I just wanted to ask one question with the malaria vaccine. I guess what we worry about is that, yes, it's not full protection, but therefore what happens if we are actually protecting these children and then later on when they grow older, they are actually have no immunity and therefore they develop severe malaria? Because the truth matters, I remember in Southeast, when we looked at the work in Southeast Asia, where there was all this DDT spraying, and then it was suddenly stopped and it was a rebound. And then you had all these people coming down with severe malaria. That's what worries me with the vaccine, in that will it protect them to a certain level, and then when it wanes off, they've now become susceptible to severe malaria because they have no immunity.
So those are issues that are now going on in terms of the longitudinal aspect of the study. For now, we don't think there are any fears, but the question generally is that, okay, you give the vaccine first 3 doses within 5, 6, 7 months of life. You give another dose between 9 to 12 months later. Cumulatively, all of this exact an influence for about a year or 2 over the patient. So there are still a little bit of logistic question as to what happens next. But you see, because there are also other interventions going on concurrently to reduce malaria burden and all that, we are for now at a stage of taking it all on and then tracking what happens in the future as we continue with this effect. But right now, we are not having significant fears. So we hope that if you look at the next 5 years, maybe we might reach a point of convergence where total burden of malaria is actually low.
Well, thank you, Benga, for your time.
So
I know you have to
you will release me. Yeah, they are
I know you have to go now.
There.
I know.
Yeah.
So I'm sure you have to go now. So thank you. And I'm sure other questions will asked on the chat box. Thank you very much. Over to you.
Dr. Hanga, please, you can text me. I will reply you if you send me a message. Thank you.
Thank you so much, sir. Thank you for the excellent presentation. I'll send the text message.
Okay.
Thank you very much, Benga.
As
expected, you did justice to it.
Okay.
Dr. Mbalaji Lawal, sir, your final thoughts. Dr. Mbalaji Lawal.
Okay. Hello.
Hello, sir.
Yes, we can hear you, sir.
Okay, yes, very briefly. Altogether, a very, very educative and interesting afternoon. Thanks to the excellent and very lucid presentation by the speaker, Professor Mokolu. Benga, thank you very much indeed.
Thank you, sir. It's a big honor,
and also for everyone who has participated so enthusiastically, the questions and comments, a very vibrant afternoon. Thank you all very much. Thank you in particular to Professor Grange, who keeps joining from diaspora. We are very happy to have this afternoon. Like I said earlier, we should be having these sessions on media very often. because it's a very popular and very, very fascinating subject all the time. Thank you all.
Yeah. Thank you so much, sir. All right, sir. I must sign out now.
Okay, Benga, thank you so much. We'll talk later on. And just to say thank you to everyone again for being on this call. The next presentation next month, hopefully, will be given by Dr. Tari Biu. So we look forward to another exciting time. Last Thursday of the month of October. Thank you very much and have a wonderful anniversary on October 1. God bless you all.
I think you need to, sir, before you sign off, just tell us that I'm going to share the link for the talk shortly so that people can listen again. And
oh, sure, we'll do that. We'll post it to all the various groups. Thank you very much.
Yes, thank you, everyone. Bye-bye.